Oh, we got one more minute. Yeah, probably. All right, everybody, welcome on this cold morning. As you can tell, I am a not tall Jewish guy, but I'm not Larry Schwartz. I'm introducing Pat for Larry Schwartz. So, I know it's not a pertinent topic to a whole bunch of people who don't do pediatrics, but you know, you can learn something from everything, I think, and I definitely learn a lot from the adult side all the time, so I think it's worth it. So this is my friend and colleague, Dr. Patrick Fernandez. I have a bio here. Dr. Fernandez attended medical school at the University of Colorado School of Medicine at this Denver campus. From here, he went on to anesthesia training at Dartmouth-Hitchcock Medical Center in New Hampshire. He came back to Colorado and completed training in peds in 2012. He has clinical interest in acute pain management, regional anesthesia, and craniofacial reconstruction in pediatric patients. He represents Children's Hospital Colorado nationally for the Wake Up Safe and Pediatric Craniofacial Collaborative Groups. He's lectured nationally and published on pediatric food allergy, which is actually a great article if anyone wants to read it. He's also published on the perioperative considerations for complex pediatric cranial vault reconstruction. Personally, he's a great guy. He's a go-getter. He is one of the people I've relied on a lot in my professional career. And so without further ado, the man with the hair, he's got great hair. This is Pat Fernandez.
Thank you, sir. All right, can everybody hear me okay? In this full room, I'd like to give a shout out to Mother Nature for dialing up a perfectly timed snowstorm this morning. And we'll go ahead and get started. First of all, the obligatory no disclosure slide here. I have nothing to disclose, no conflicts of interest at all. So for this pediatric update, I've chosen 3 specific topics. These topics have been in the literature over the past year or two. And so in the next 45 minutes or so, I'm going to sort of move us through these 3 topics. I'm going to begin with the perioperative management of the food allergic pediatric patient, so you don't have to read that article. I'll move on to a little bit of rethinking the NPO guidelines in pediatric anesthesia and rapid sequence induction. And I'll conclude with an update on pediatric craniofacial reconstruction. There's been a lot in the literature lately about this and some updates there. So let's begin with this discussion about food allergy and how it may or may not impact our anesthetic management of pediatric patients. And really this probably applies to adult patients as well. So to put this into a logical framework, I like to think about this sort of the overarching question here as whether or not an overlap exists between food allergy and exposure to perioperative substances. Thinking about this in allergy terms, are there immunologic epitopes common to foods and substances that our patients are exposed to that may lead to cross-reactivity and an allergic reaction in the OR? So to begin answering this question, I think I first need to address the common misconception that food allergies are actually on the rise. There certainly is a perception that more and more children have food allergies. However, there was a comprehensive report published by the National Academy of Sciences in 2016 that sort of debunked this idea. They looked at the literature available and found that the true prevalence of food allergy is really difficult to ascertain. This is based on the fact that the data available is in too varied of patient populations. So when you compare adult food allergy to child food allergy, the pathophysiology and the pathology of it is different. And studies are often based on patient and parent survey reports. So that certainly muddies the waters in terms of whether or not a patient had a true allergy. So due to these issues, there really is probably an overestimation of the prevalence of food allergy. And I'm hoping that the following patient case will highlight why I think this is an important topic for us in this update. So about 9 months ago, I was asked to see a patient in our preoperative clinic. This patient's mom had concerns about a prior anesthetic that was done at an outside hospital and wanted to come and chat with me about that before she was anesthetized with us. So this patient, let's call her Emily. She was a 7-year-old girl. She had a history of multiple food allergy, a history of anaphylaxis to egg, and a family history of malignant hyperthermia. During our conversation with her mom, it became clear that propofol was actually avoided because of this egg allergy, and instead dexmedetomidine was used. Mom had a concern that during the anesthetic and postoperatively the patient was bradycardic, likely due to the dexmedetomidine, and she was here to talk about this with me and how we could avoid that. So with Emily's case in mind, let's move on to a broader discussion of food allergy and see if we can determine whether or not propofol actually needed to be avoided in her. So food allergies, like the one Emily had, are a subset of adverse food reactions. These encompass a broad range of pathology that include immune-mediated, non-immune-mediated, and toxic reactions. Specifically, allergic food reactions in particular fall into the immune-mediated branch of this pathway, and they can either be IgE-mediated, non-IgE-mediated, or a mixture of the two. While a good estimate of the prevalence of food allergy eludes us, we do know and have some knowledge about what foods people are most likely to be allergic to. More than 170 different foods have been determined to be allergenic, but the 8 foods listed here account for 85% of all known food allergies. In addition to knowing what common food allergies are out there, another important factor, I think, is the natural history of these food allergies. Specifically, are they lifelong hypersensitivities, or are patients potentially able to outgrow these later in life? So allergies to egg, milk, soy, and wheat, for example, are commonly transient over a lifetime, with most of the literature agreeing that people will outgrow these, certainly by adolescence. Alternatively, allergies to nuts, shellfish, and fish tend to be more persistent over a lifetime and can even develop later in life, even in adulthood. There is some literature emerging that as much as 20% of patients with a nut allergy will potentially even outgrow this later in life. Notably, nut allergies are among the most deadly, as we probably all know, and account for greater than 90% of fatalities due to allergic reactions. So without boring you with the details of the pathophysiology of a type 1 hypersensitivity reaction, I will simply state that the allergy and immunology literature defines a complete or immunodominant allergen as a substance that is capable of inducing a sensitization and triggering a reaction. This table here lists the most common allergens responsible for common food allergies, but the take-home point here isn't the details, it's that proteins tend to be common food allergens. So with the background knowledge that common food allergies, I'll now turn my attention to the perioperative setting and how we should think about these patients as they present for anesthesia. When it comes to the preoperative phase, one thing to consider is the potential role for preoperative allergen contamination. Those of us in the room who have children in school, we're all familiar with the nut-free table in the school cafeteria. This begs a few questions in my mind. Should hospitals be nut-free? Pediatric hospitals specifically. What is the type of allergen exposure and minimum allergen exposure that is needed to trigger a reaction? And how are allergens decontaminated or cleaned up? Given that nut allergy, as I previously said, are among the deadliest of food allergy reactions, these exact questions have been known for over a decade. Some key facts relevant to us include the fact that ingestion of nut allergen is typically necessary to trigger a significant reaction. Casual contact or even just inhalation of allergen does not typically pose a significant risk. And the study shown here highlights that looked at the most common peanut allergen and how easily it is able to be cleaned up. They found that using soap and water and typical household cleaners, most allergen is pretty easily cleaned. Interestingly, the alcohol hand sanitizer that we use wasn't sufficient to completely decontaminate this nut allergen when they looked at it. So when we're thinking about this preoperatively, I think it's comforting to know that our typical OR cleaning strategies probably decontaminate any nut allergy that may be present in the OR. And we should probably be washing our hands after we eat before returning to patient care, kind of like our moms already told us to do. So now let's shift gears to the intraoperative environment from the preoperative phase. As we all are aware, the incidence of intraoperative anaphylactic reaction is low, with estimates ranging from 1 in 6,000 to 1 in 20,000. Furthermore, we all understand that there are certain medications that are implicated more often than others, shown in the table here. The top 3 substances include muscle relaxants, latex, and antibiotics, and they account for nearly 90% of all perioperative anaphylactic reactions that are seen. So with my prior discussion of common food allergy knowledge and knowledge of the culprits of perioperative allergic reaction, let's look to the literature to see if we can find that overlap that I talked about earlier. So I think we can quickly dispose of a concern for neuromuscular blockers and food interaction. The theoretical concern with this is that there's a cross-reactivity with tertiary and quaternary ammonium ions, and there is really nothing in the literature that supports a food allergy connection to cross-reaction with neuromuscular blockers. Moving forward, there is evidence for interaction between latex and certain fruits, and I will briefly highlight this. I'll quickly demystify any connection that there may be between a seafood allergy and perioperative medications, in particular iodinated media and protamine, and talk about one potential exception there. And finally, allergy to egg, soy, and peanut, I think are probably the ones we all think about or used to think about when considering a connection between food allergy and reactions to substances we give in the OR, and I'll summarize the literature on this topic. So to begin, with respect to the latex food allergy, the latex fruit syndrome was first defined by a Spanish allergist named Carlos Blanco in 1994. Specifically, IgE antibodies made to epitopes on latex are known to cross-react with certain fruits, specifically banana, avocado, and kiwi. So the question arises, what comes first? Does an allergy to latex establish cross-sensitivity to avocado, or should a patient with known avocado allergy be on latex precautions? And the available data actually shows that both can occur. For example, a patient that is allergic to latex can have increased IgE to certain fruits, even if they've never been exposed to these fruits. And alternatively, occupational exposure to certain fruits can lead to increased risk for latex allergy. So because of this phenomenon, it's my opinion that latex precautions should be in place for all patients who are allergic to these fruits. So moving on to the seafood and fish allergy question, patients can be exposed, as we know, in the OR or perioperatively to iodinated media and protamine. There has been a theoretical concern regarding cross-sensitivity with fish and seafood allergy for these substances. So with respect to iodine, the concerning interaction with seafood allergy is actually based upon myth, and it's really not substantiated in the literature. According to the American Academy of Allergy, Asthma, and Immunology, 3 facts dispel this myth. So the first is that reactions to iodinated media that happen, that are seen in the OR or perioperatively, are not actually due to IgE-mediated reactions to iodine. Secondly, contact dermatitis that might be seen from iodine surgical scrub, for example, is not triggered by iodine. And finally, consistent with what I presented earlier, the muscle proteins found in seafood, for example, tropomyosin, are the cause of allergy to seafood, not iodine. Unfortunately, in the case of protamine, the data concerning a potential cross-reactivity with fish allergy is less straightforward. The connection between fish allergy and protamine stems from the fact that most commercially available formulations of protamine are derived from salmon. And protamine is a simple, low molecular weight protein, and therefore, based on my previous slides, could result in an IgE-mediated reaction. The package insert from one protamine manufacturer includes fish allergy as a risk, but also emphasizes that to date, really no relationship has been established in a link between allergic reaction and an allergy to fish. So in my opinion, if there is sufficient concern, patients should be tested for fish allergy and protamine prior to any exposure to protamine. And results from this testing could warrant the use of alternatives to heparin. And there certainly are case reports in the adult literature of direct thrombin inhibitors being used as an alternative to protamine in this very situation. So I'll wrap up the discussion here with propofol. As I said, this is likely the thing that we maybe used to think about or still do in terms of a food allergy connection with anesthetic agents. So the first thing to consider here is what is in propofol that we're worried about, namely soybean oil and egg lecithin. Looking at intralipid will prove an important point. Notice that the same food components are present. Also notice that none of these are proteins, and per my earlier discussion about immunodominant allergens, the food components in propofol are really unlikely to trigger a reaction to anyone with a known allergy to egg or soy. Now let's take a look at the contraindications for these two products, and hopefully the interesting point here is obvious. There is no mention of egg and soy allergy as a contraindication to intralipid as there is for propofol. So with this knowledge about food components found in propofol, let's finish the discussion with a look at the available literature. Since the early 1990s, an attempt has been made to link food allergy to propofol use through case reports and retrospective studies. And the 4 publications listed here are a comprehensive summary of what I think is the best available data concerning propofol and allergy to egg, soy, or peanut. Studies from 2011 to 2017 all point to the same conclusions. Propofol is safely used in patients with allergy to egg, soy, and peanuts, and the practice of choosing alternatives to propofol in patients with these food allergies is not evidence-based and should be reconsidered. So to bring this all together, I'll return to our patient, Emily, that I introduced earlier. Based on current literature, evidence does not support concern for any food allergy interaction with modern anesthetic agents. Furthermore, the preoperative evaluation could be used as a time to educate patients or parents about this fact. So when considering an anesthetic plan, I don't think that a patient's anesthetic needs to be changed out of concern for food allergy in particular. I think any atopic patient should be deemed at higher risk for a perioperative reaction, whether or not they have a food allergy. And ultimately, reasonable concessions could be considered if a patient or a parent is adamant about avoiding certain medications, again, if it's a reasonable concession. So I'm going to stick with the theme of eating and not eating and move on to the topic of rethinking NPO guidelines in pediatric patients. And a lot has been published about this really in 2018. So we all know the purpose of NPO guidelines. The ASA updated their practice guidelines in 2017, so we'll turn to them for the definitive answer. The purpose of these guidelines is to reduce the risk of pulmonary aspiration and to reduce the severity of complications from aspiration. This 2017 update from the ASA really came to the same conclusions about the MPO rules that we already know, the so-called 2468 rules listed here in this table. The ASA updated their guidelines and published them in March of 2017. Almost a year later, in February of 2018, leaders from the Pediatric Anesthesia Societies of Great Britain and Europe signed a consensus statement that was published in Pediatric Anesthesia, specifically related to clear liquid NPO times. In this statement, they agreed on a change to the clear liquid NPO guidelines, specifically that patients should be allowed and encouraged to have clear liquids up to 1 hour before elective general anesthesia. So I'll now move on to some of the data that influenced this decision and some related articles. First, let's go back to the reason for all of this: prevention of pulmonary aspiration, and how this influenced thinking about the change in these MPO guidelines from the pediatric perspective. Data from as far back as 1998 has shown that the incidence of aspiration in pediatric anesthesia care is actually rare, and this is especially true when we're talking about healthy children with few medical comorbidities. Furthermore, studies have shown, in the past several years, have shown that the morbidity from these rare events tends to be low. So looking more closely at morbidity, a group from the UK published data from a large prospective multi-center survey that included just over 118,000 pediatric anesthetics from 11 centers over a 12-month period. They found 24 cases of aspiration in this cohort, with an incidence, giving an incidence of 2 in 10,000. A similar incidence was found in both elective and non-elective anesthetics. 5 of these 24 cases suffered what they called severe deterioration, requiring ventilation for some period of time that varied among these patients. All of them made a full recovery. Notably, the authors did conclude that part of the explanation for this low incidence of aspiration was probably related to the fact that these patients were cared for at specialized pediatric centers. Another study that included over 139,000 patients, published in 2016, seems to corroborate that aspiration is a rare event in pediatric anesthesia and sedation in the United States. Furthermore, the incidence of aspiration events were similar whether or not patients were appropriately MPO. While these two studies seem to show that the risk of perioperative aspiration is likely low, I still think it's important to note that we should still recognize patient and anesthetic factors that influence this risk. And this table is simply a summary, not exhaustive summary of these risk factors that we all are already aware of. So I'll now turn to literature published in the past year, really, that supports a liberalization of clear liquid NPO rules in pediatric patients. Data published in 2011 began to shed some light on the fact that actual fasting times in children tend to be excessively long despite our current NPO guidelines. In 2011, work from the UK showed that the median fasting times were 12 hours for solids and 8 hours for liquids in elective outpatient children. In 2016, in the Journal of Pediatric Surgery, reported that MPO time was greater than recommended in over 70% of patients. And in that same year, another study showed that 62% of patients fasted longer than 4 hours for clear liquids. So it's clear that we are obviously not doing a great job following the rules that we're supposed to be following as they are intended. Furthermore, the drawbacks of prolonged fasting are also well documented and include those listed here, things like metabolic acidosis, intraoperative cardiovascular instability, and even emergence delirium. Delving into just one of these a bit deeper, a group from India published an interesting paper providing some evidence of a correlation between prolonged preoperative fasting and emergence delirium. This group looked at 100 children with a mean age of 4 years old, all of whom were undergoing EUA of the eyes. Their logic was that by looking at only eye exams, perhaps they could eliminate any emergence agitation that would be attributed to postoperative pain. Part of the study, a blinded anesthesiologist used a validated pediatric emergence delirium scale to assess patients in PACU for the first 30 minutes post-op. And they hypothesized that the duration of preoperative fasting would contribute or be related to postoperative emergence delirium. So, in addition to corroborating the building evidence that kids tend to be fasted for way longer than intended, here with a mean clear liquid NPO time greater than 3 times the intended or current guideline recommendation, they also showed a correlation between greater emergence agitation and prolonged fasting. So if there's data that unintentional prolonged fasting is commonplace, and it's probably detrimental. Sorry, is it back? Okay. And that this prolonged fasting is probably detrimental. What's being done about it, and is there a way we can fix this? So in March of 2018, the German Pediatric Anesthesia Work Group actually addressed this in their Choosing Wisely manuscript and listed this as one of their top 10 most important do's and don'ts. Evidence presented by this group includes what I've already presented, the fact that there's a low risk of aspiration in healthy pediatric patients, as well as the documented incidence of unnecessarily long fasting times when our current guidelines are being followed. These authors touched upon the benefits of altering the NPO timing guidelines for clear liquids, but they also went a step further and even suggested that we liberalize light meal NPO times to 4 hours. So the story building up to this point is that liberal fluid fasting should be considered, but has this actually been done? What is the experience? A group from Sweden published compelling data showing that liberalized fluid fasting reduces unnecessarily long fasting times. In the study shown here, they compared preoperative duration of fasting for patients following the traditional 2-4-6 rule to a more liberal 0-4-6 rule. Specifically, the 0-4-6 rules were defined as clear liquids up until going to the OR, which was typically about 30 minutes prior to induction. 4 hours for milk products, including breast milk, formula, yogurt. Furthermore, parents of patients under 12 months were encouraged to wake their children 4 hours prior and feed them if they were the first case of the day. Fasting from midnight for solids was still instructed, but 6 hours was accepted in appropriate patients. And I think the key thing here is that all of these guidelines and the appropriateness of these rules were applied based upon a risk assessment on an individual patient basis by the anesthesia provider. So comparing these two groups, it was found that children under 3 years and those scheduled for the first case of the day were at increased risk for prolonged fasting times. And with their plan implemented, the median duration of fasting for clear liquids decreased from 4 hours to 1 hour, and the incidence of prolonged fasting significantly decreased as well. So liberal fluid fasting can be done, and it has a positive impact at reducing this unnecessarily prolonged fasting time. But what about its impact on gastric contents? Another group from Sweden looked at the impact of liberal fluid fasting on gastric pH and residual volumes. They compared, similar to the last study, a liberal fluid fasting regimen to a standard 2-hour clear liquid NPO time. So in addition to corroborating the impact on a prolonged fasting times, they also found that liberal fluid fasting did not impact gastric pH or gastric volume when compared to patients following a traditional 2-hour rule. So with this in mind, the benefits of child-friendly NPO times are becoming apparent. Some proven benefits, in my mind, include decreased preoperative fasting times from this unnecessarily prolonged situation we're in, decreased incidence of this unnecessarily prolonged fasting, and decreased thirst, hunger, and anxiety. Things that are likely beneficial but have yet to be studied include decreased perioperative hypoglycemia, improved intraoperative hemodynamic stability, decreased post-op insulin resistance, and even decreased emergence agitation. So I'll conclude with a summary of a pro versus con discussion that was actually published in a review in the British Journal of Anesthesia last year. Those who would argue for a liberalization of NPO times argue the following points. As I presented earlier, despite the 246 rules, the majority of children are starved much longer than intended. And aside from a crabby child and probably crabby parents, this may lead to hypoglycemia, dehydration, and intraoperative cardiovascular instability. Both old and new data about gastric emptying shows that stomach contents are likely cleared pretty rapidly in children, with a light meal clearing within 4 hours, and certainly clear liquids much faster than that. There's not good evidence that our current NPO guidelines really do anything to protect against aspiration. And finally, aspiration, as I highlighted, is a rare event, and when it does occur, its sequelae are typically rarely substantial. So on the converse side, those against moving away from what we've always done, they argue, does liberalization of NPO time go too far? As I've already shown, highlighted, and there are other studies highlighting the same, numerous studies have shown that the issue of this unnecessarily prolonged NPO times can simply be addressed by quality improvement initiatives that just bring it more into the 246 rule realm. It's certainly the case that application of a more liberal, child-friendly NPO guideline cannot be universally applied to all patients, and we need to individually assess these patients as being appropriate. Studies showing that liberalized NPO rules are not associated with increased incidence of aspiration rates were not powered to show this. So can we really say this is a safe thing to be doing? And some simply present the if it isn't broken, don't fix it argument. After all, aspiration is exceedingly rare under the current guidelines, so why are we messing around with it? Ultimately, I think this is a compelling discussion. Clearly, our colleagues in Britain and Europe are comfortable moving forward with this. But again, I need to reiterate that I think these more liberalized NPO guidelines need to be looked at an individual basis when assessing potential risk to patients. So I'd like to round out this discussion about preoperative fasting with a quick look at a pro-con debate about pediatric rapid sequence induction that was presented at the ASA recently, I think last year. So one side of this debate is to stick with the classic RSI technique, citing the fact that aspiration still happens and we're preventing it, and that the use of cricoid pressure is easy and effective. The argument for a new, quote, best practice rapid sequence technique in pediatric calls into question a few facts. One, how frequently and how significant is perioperative aspiration in pediatrics? Are we actually preventing aspiration with the classic technique? And is cricoid pressure actually easy and effective? I think I've presented some evidence that aspiration in children is rare and often of low morbidity. But what about the other two arguments? First, let's quickly look at the difference between this classic versus best practice RSI. So classic RSI is just that, the classic way we were all taught. Pre-oxygenation, cricoid pressure, induction medications, including a neuromuscular blocker, and then intubation. Those who propose a so-called best practice or new way of looking at this call into question really the effectiveness of cricoid pressure and propose adding the gentle bag mask ventilation, the so-called modified RSI. So with respect to the ease of applying cricoid pressure, multiple publications have shown that cricoid pressure is poorly taught, it's frequently done wrong, and it can carry risk of damage or airway obstruction. And those of us who've tried to intubate a baby with cricoid pressure can attest to that. Furthermore, there really is no evidence that classic RSI technique that it decreases the incidence of aspiration, leading to the less than definitive conclusion that our current RSI can neither be supported nor discouraged based on current literature. So given that there is really no definitive answer here, this table I hope lists some things that we can all agree on. First, pre-oxygenation is good if we can do it. Obtaining ideal intubating conditions is important, and we shouldn't fear the use of succinylcholine when appropriate. We should consider gentle bag mask ventilation during this situation, and correct cricoid pressure may not be as easy as we all think. So I'm going to totally shift gears here now and get away from eating and not eating or drinking and not drinking and move to and round out this update with a discussion about what's new in the realm of pediatric craniofacial reconstruction, because a lot has been published really in the last year or two on this. So as pediatric anesthesiologists, we all know the complexities of cranial vault reconstruction for craniosynostosis. These procedures present some of the most significant risk for complications in the smallest patients that we're asked to care for. Among the challenges listed here are massive blood loss and transfusion, the potential for difficult airway, and oftentimes challenging vascular access. In 2011, the Pediatric Craniofacial Collaborative Group was established in an effort to collect multi-center data pertaining to the management of these patients, and to ultimately leverage this data and this information to foster multi-center research and improve care. The group established the world's largest pediatric craniofacial perioperative registry, with data currently being provided from an international consortium of more than 30 institutions from the United States, Canada, Colombia, and Mexico. And to date, this group has published 7 papers since 2017. And I'll spend the remainder of my time highlighting some of the important take-home points from some of these publications. The majority of the publications from this group has focused on the most complex of these patients, the highest risk, and these are how they've defined it as the complex cranial vault reconstructions. These include those listed here: the frontoorbital advancement, which is commonly used to correct coronal and metopic synostosis, as well as posterior and total vault reconstructions. Important knowledge about the surgical procedures and perioperative management of these patients was revealed in the initial benchmarking study from this group. From a surgical perspective, the vast majority of these patients, these complex cases, have an anterior vault or frontoorbital advancement surgery, and the overwhelming majority, when they present for this reconstruction, it's their first craniofacial surgery. With respect to anesthetic management, while no single anesthetic technique is prevalent or recommended over another, the overwhelming majority of patients do get 2 peripheral IVs, an arterial line, while central access seems to have actually fallen out of favor, being reserved for instances where IV access is very difficult or where a central line is otherwise indicated. In terms of additional monitoring during these cases, the precordial Doppler is no longer commonly used, and the use of TEG is also rarely employed. Given that significant blood loss is a major concern in these surgeries, information about effective blood conservation techniques is important. Historically, multiple strategies have been employed to varying degrees, and here is some up-to-date advice regarding a few of these strategies. First, acute normovolemic hemodilution is essentially not used. While slightly more commonly used, preoperative erythropoietin is also rarely employed. And there are several concerns about its use in otherwise healthy patients. Intraoperative cell saver, to me, is an interesting modality with documented successful use. However, there are several barriers to overcome with its use, including its cost, its availability, and how it impacts the surgical technique. And finally, the blood conservation technique, really with the strongest evidence, is the use of antifibrinolytics. This is supported by positive data from 2 randomized placebo-controlled trials of tranexamic acid that has shown a decrease in blood loss and transfusion specifically in these patients. While the majority of the contributing institutions to the perioperative registry employ this technique, there is still some room to encourage more widespread use, in my opinion. And I will comment on the safety of its use in a few slides later. Sticking with the blood transfusion theme, while these blood conservation techniques are available, they aren't universally employed, nor are they capable of entirely mitigating the need for blood transfusion in these complex cases. Indeed, the vast majority of complex cranial vault repairs receive some blood product transfusion to some degree. Importantly, over 40% of these patients receive a significant volume of blood product transfusion. And this is clinically relevant because data has shown that the greater volumes of transfused blood products is an independent predictor of the need for postoperative ICU admission. We do have some insight into what predicts the need for blood transfusion, and those are listed here. Things include patient factors like lower weight and greater ASA status, surgical factors such as greater surgical duration, and the lack of antifibrinolytic use. Notable perioperative factors that seem to not be significant when predicting the likelihood of intraoperative blood transfusion include other patient factors like sex, race, or ethnicity, the preoperative administration of erythropoietin, which may be further support for avoiding its use in these patients. Interestingly, syndromic, multi-suture, and even redo procedures were not predictive of increased blood transfusion. This may highlight the fact that the more important factor when it comes to bleeding and blood transfusion for these cases is surgical duration rather than any perceived surgical complexity. So I'd like to circle back as promised and discuss what is recently available in the literature when it comes to the safety of the use of tranexamic acid in these patients. As highlighted earlier, the literature really substantiates that the use of TXA decreases blood loss and blood product transfusion in complex craniofacial surgery, and really all craniofacial surgery. However, there is concern about the risks that make some anesthesia providers and even surgeons leery about using this. Chief among these concerns is the risk for thromboembolic events and seizure. So using the database that I presented earlier, collaborators have provided some insight into the safety, and that's the study shown here. They found that there was a very low overall incidence of postoperative seizure in these patients. There was no correlation between the use of antifibrinolytic and an increased risk of seizure. In the over 1,600 cases that were evaluated in this particular study, only a single instance of postoperative DVT was noted, and it was associated with a femoral venous catheter in a medically complex patient. The authors here concluded that the use of TXA is likely safe in these patients, but caution should be used in high-risk patients, and high doses should be avoided. So I'm going to wrap up this discussion by talking about the latest data in the realm of minimally invasive or endoscopic assisted craniofacial repair. And this is something that, in my opinion, is going to become more and more prevalent. So endoscopic assisted repair can be applied to most types of craniosynostosis, including multi-suture repairs. It's typically reserved for young patients, children under 3 months of age. And there are significant advantages to endoscopic repair over open repair that have been shown in single-center studies and recently substantiated by multi-center data from the database. These include less perioperative exposure to red blood cells and coagulation products, resulting in an overall reduction in blood donor exposure. There's a less frequent need for post-operative intubation in these patients. Patients who undergo an endoscopic repair are less likely to be admitted to the ICU post-operatively, and those who are admitted to the ICU enjoy a shorter ICU stay. Overall, these patients benefit from a shorter hospital length of stay, and this all translates into decreased morbidity and mortality and likely decreased healthcare cost. So, to conclude, a few important take-home points that I think when considering an anesthetic for complex cranial vault repairs in infants are the following. First, I would consider reserving central venous access for those who are difficult to obtain IV access, or if for whatever reason a central line is otherwise indicated. Certain perioperative factors like decreased weight, increased surgical time, higher ASA class are all predictive of intraoperative blood exposure, and that may help us when planning for these surgeries as anesthesia providers. Given the good evidence and a clear advantage and evidence pointing towards safety, the use of TXA should be considered on a low-dose regimen, and the regimen that we use here based on the literature is listed. In the future, cell saver use may increase, and we're starting to try to do this at Children's Hospital. As reservoir bowl volumes become smaller, as the technology becomes more readily available, and as we're able to convince our surgical colleagues that it's a good thing. Certainly, endoscopic assisted repair is going to become more and more prominent given all of its advantages. And at our institution alone, we've seen a significant increase in the use of endoscopic assisted repair just in the past year. And finally, I think it's important to keep an eye out for more from this collaborative group. It's a good place for future developments in the realm of craniofacial repair. And with that, I will answer questions.
What do you think about us versus Europe? Do you think they practice differently? Do you think they do fewer cases and travel less during the day, bringing cases about? And then also, when you make a blanket policy like that, do they get seen in the procedure clinic in Europe more so than they would get seen here? I mean, I see a lot of confusion on the adult side. Mm-hmm. You can have this, but you can have this, and then you can have that, and the next thing you know, they had a full breakfast.
Yeah. I think it's a good point, and I think I've chatted with Kim Strupp about this. She and Matt Wilder were and a few others were part of trying to really just normalize our MPO guidelines, because we found that through all the surgical clinics, patients were being told different things. So I think it's something, like I said, I think it's an interesting thing. I think it may be more difficult to implement than maybe they let on. Certainly the key is that, individual patient assessment, and we can't just sort of blanket say everybody's okay for 30 minutes to go back in terms of NPO guidelines. So I don't think we're moving forward with it. I think it's something that certainly the fact that these patients were cared for at specialty centers and they have, the eyes of specialty pediatric providers on them, assessing them is not something that can be universally applied everywhere. So I think it's an interesting point. It was all over the literature in the past year, so it's something, something that may be coming. Or I know that at the Wake Up Safe meeting, I can't remember. Do you remember, Kim? Yeah, I think Pittsburgh was they were doing a QI initiative I think more to look at where did they sit in the unnecessarily prolonged realm and how can they make that better rather than introduce a 30-minute or 1 hour NPO time. So I think the better thing is to do is probably look at how poorly are we doing with it and try to bring it into the realm of what we are intending. So
one of the things they did was develop a standing order set for patients that came into pre-op, and they gave them clear liquids like the minute they hit the door. So they involved the pre-op nurses, and at that point, you have when you're 2 hours before their OR time, you have a much better idea. Are you running on time? Are you running behind? Is there something else going to bump you? Versus telling them to drink up until the minute they come in, and now you have a cancellation before. So that was the thing we struggled with when we were writing the guidelines, because we actually changed from 2 hours before their surgical time and 2 hours before their arrival time to allow for that flexibility, knowing that the anesthesiologist could still give them clear liquids and pre-op if they were running behind. So if I were to change anything about our guidelines, I might make an exception to the individual anesthesiologist to say, if you have a healthy child undergoing an elective procedure and you want to give them clear liquids up till an hour before, it's supported by the literature from Europe. But I would never give those instructions to the patients themselves because I think it would be way too confusing and way too difficult to apply unless you had one person calling every patient that's coming in, and our system at this point is just too big to handle that. For 3 minutes.
Maybe we had a half a month, so that the MPO can communicate with the pay, the way, and MPO has to be discussion. No, so we not have that answer for him. Do we know what is the percent of the patients who actually are seen in Europe as opposed to the United States?
no, and I'd have to look back. I don't think it was specifically highlighted in any of this literature that, what percentage of these patients are actually seen. I don't know that it's any greater than here. We tend to just see the most complex or, the most worried parents, really. Yeah. Yeah.
And it's just a small study, so they watch it pretty carefully.
Yep.
It reminds me of these studies of hypoglycemia and high management of Cooper. Remember those days? And they would say, well, we have to sit between 80 and 120, and we have to think everything about 120. Remember for a while again, everybody was hypoglycemic because we were overreacting. So we kind of thought about it for me before you enter this next.
Yep. Yep. Any other questions? Okay. Thank you.